Hello everybody, my name is Dr. Amit Shah. I'm a consultant medical and hematological oncologist working in East Midlands. Today our talk will be about hypertension in pregnancy and we'll include a case study in it. So what is hypersensitive disease? We know that it complicates 12 to 22% of all pregnancies and it's the most common medical complication during pregnancy. Complications include abruption, cerebral hemorrhage, DIC, hepatic failure, eclampsia and acute renal failure. Hypertension refers to a systolic blood pressure of 100 millimeters or more and a diastolic BP of 90 millimeters or more. Mild hypertension refers to a systolic BP of 140 to 159 or diastolic BP 90 to 109, and severe hypertension involves systolic BP of greater than 160 or diastolic of greater than 110. Chronic hypertension in pregnancy. We know the onset of this is generally before the 20th week of gestation, with a blood pressure of 140/90. This is usually resolved with antihypertensive drugs used before pregnancy, which include thiazide diuretics, calcium channel blockers, ACE inhibitors, angiotensin II receptor antagonists, and beta blockers. There is generally persistence of hypertension greater than 12 weeks postpartum. Gestational hypertension. This is defined as the new onset of hypertension after 20 weeks without proteinuria, with blood pressure of over 140/90. This could be a transient diagnosis with normal levels returning by 12 weeks postpartum. Could also represent pre-proteinuria phase of preeclampsia, which may evolve to preeclampsia. Preeclampsia is a complication of pregnancy with symptoms including high blood pressure, high levels of protein in urine that indicate kidney damage, proteinuria, or other signs of organ damage. This is often a retrospective disease as the consequences of the condition are unknown. Chronic hypertension with superimposed preeclampsia. This is hypertension in early gestations that develop proteinuria before or after 20 weeks. There is an exacerbation of hypertension or need for increased medication to control it. You generally have alterations in lab values, decrease of platelets, which is less than 100,000, and an elevation of liver enzymes to twice the normal concentration. You'll find there's a development of symptoms including headaches, epigastric pain, and pulmonary congestion or edema. So what is preeclampsia? Preeclampsia affects 3 to 7% of pregnant women. There is generally a late onset of preeclampsia in up to 25% of cases, postpartum 4 days to 6 weeks. Patients present with systolic blood pressure of over 140 or diastolic blood pressure of over 90, twice at least 4 hours apart. The risks include nulliparous patients, which is a woman that has not yet given birth to a child, or first pregnancy with a new partner. Maternal age is a factor because it occurs more frequently among teens and women over 35 years of age. Placental size is a factor. Pregnancies in which placental size is increased have higher incidence, e.g. multiples, diabetes, etc. African American race have a high percentage of preeclampsia. Patients with a history or family history of preeclampsia, chronic hypertension, thrombophilia, as in lupus, factor V, Leiden mutation, etc. So to check for proteinuria, urine analysis is the usual and best approach. 300 milligrams per 24-hour urine. Protein creatinine ratio is over 0.3 milligrams per DL and a dipstick reading of +1. Only use this method if other measurements are not available. If there is no protein, use one of the following assessments. Platelet count of under 100,000, serum creatinine 1.1 over 1.1 or doubling of creatinine, liver enzymes elevated to twice as normal, pulmonary edema, or check for visual disturbances, e.g. headaches, epigastric pain, etc. Preeclampsia with severe symptoms. These are patients with systolic blood pressure of over 160 or diastolic of over 110. 2 blood pressure readings should be conducted at least 4 hours apart. Patient might have oliguria, which is low urine output, which is under 500 milliliters in 24 hours. Pulmonary edema, which is epigastric pain that is unresponsive to medication. They might have abnormally elevated liver enzymes, which twice the normal rate. Thrombocytopenia, which is under 100,000 platelets. Renal insufficiency with a creatinine of 1.1, double the baseline. Those suffering from HELP syndrome, hemolysis, elevated liver enzymes, low platelets, will need priority treatment. Pathophysiology of severe preeclampsia. The characteristic pathophysiological features of preeclampsia are systemic vasoconstriction, vasospasm, decreasing blood flow to tissues and cells, endothelial damage causing escape of intravascular volume, decrease in circulating plasma volume, platelet aggregation resulting in microvascular obstruction. The characteristics of progressive end organ damage are brain, as in headache, vision change, and seizure, liver, as in abdominal pain and nausea, kidney, as in decreased urine output and renal failures. Below you can see the effect of severe preeclampsia on the central nervous system. You can see the swelling here. This shows that it's affecting the CNS. In the scans, you can see the levels of CNS dysfunction leading to an increased risk of ICP, which is intrahepatic cholestasis of pregnancy, which is a potentially serious liver disorder where the bile ducts do not flow properly and build up in your body instead of the normal flow from liver to gut to help digest food. Vision changes, cortical blindness, severe headache, which persists despite therapy, and altered mental status, AMS, and stroke. Severe preeclampsia can lead to pulmonary edema. This is where vasoconstriction damages endothelial lining of vessels, which increase capillary permeability and leakage of fluid into the interstitial compartment. Pulmonary edema can also result from fluid overload in the pulmonary circulation, which is caused by SVR, systemic vascular resistance. Severe preeclampsia can also lead to hepatic abnormalities, specifically damage to the hepatic cell. This may progress to hepatocellular necrosis, and in most severe cases to hepatic rupture. Hepatic abnormalities can present in the form of severe right upper quadrant pain, and patients tend to have elevated liver enzymes, AST, ALT, and LDH levels. Another risk from severe preeclampsia is proteinuria, which is an increased level of pure protein in the urine. This is a prominent symptom in severe preeclampsia. The severity of progression of this may not be indicative of disease, but its presence is still important. A 24-hour urine reading is seen as gold standard to check the spot urine protein and creatinine ratios. These are the readings that we look for. 0.3 milligrams equals 200 milligrams per 24-hour urine collection. Less than 0.15 equals normal. Greater than 0.7 milligrams equals severe proteinuria. With preeclampsia, there is also a risk of thrombocytopenia, which is damage to cells and tissues which cause red blood cell destruction, platelet aggregation, and consumption of clotting factors that will repair the damaged cells. The risk of coagulation increases with a platelet count of under 100,000. You can see here the uteroplacental constriction effects. You can see here intrauterine growth restriction is where this is when a baby in the womb, a fetus, does not grow as expected. You can also have oligohydramnios, when you have low amniotic fluid during pregnancy, placental abruption, and non-reassuring fetal heart rate, FHR, and uterine activity patterns such as late decelerations. Risk of recurrence. 20% of patients will have hypertension after pregnancy, having had it before. 16% of patients will have preeclampsia. The earlier the presentation, the increasing chance of recurrence. If a patient's hypertension recurs, if they've had preeclampsia or HELP syndrome, they have a greater risk of developing cardiovascular disease. Eclampsia. This is the new onset of grand mal seizures or coma in a pregnant woman with preeclampsia. The cause of this is unknown, but theories of its etiology include cerebral vasospasm, hemorrhage, ischemia, edema, and microthrombi causing cerebral blood vessel occlusion. Hypertensive encephalopathy is an acute condition resulting from abrupt and severe hypertension, followed by severe increases in intracranial pressure. Here you can see a pie chart showing the rates of eclampsia. You can see 50% are antepartum, 25% intrapartum, 25% postpartum. Here you can see common side effects: headache, 83%, hyperreflexia, 80%, proteinuria, 80%, edema, 60%, clonus, and visual signs, 46 and 45% respectively, and epigastric pain, 20%. When a patient has hypertensive emergency, this can occur at any time during treatment of the patient, regardless of history or diagnosis. This is an acute onset of severe hypertension that's accurately measured using standard techniques, including over 160 millimeters is systolic, or over 110 millimeters diastolic, or if it's persistent, as in every 15 minutes or more. Severe hypertension. Severe hypertension causes cerebral hemorrhage and stroke. 2/3 of maternal deaths are consequences of stroke. Systolic hypertension may be more predictive of cerebral injury. The key is not to normalize. 140 to 150 systolic, 90 to 100 diastolic is a B blood pressure goal. Antihypertensives. So these are drugs that are approved now. So you have IV labetalol, Normadine or Trandate. That's known as a beta blocker. These work by slowing down the heart, by blocking the action of hormones like adrenaline. Labetalol is IV infused in the following ascending doses. You can see over here: 20, 40, 80, and then you'll move to a hydrolazine. If the patient's levels are still elevated, you might consider other options. So this is how you would infuse hydrolazine. Less known as the vasodilator. This works by relaxing the blood vessels so that blood can flow more easily through the body, and it's administered as follows: 5 to 10 milligrams IV, and then 10 milligrams IV, 20 milligrams. Then you might change to labetalol, and you'd consider other options if the patient fails on this. And remember, it's important to repeat blood pressures every 20 minutes. Oral nifedipine, or Procardia. This is a dihydropyridine calcium channel blocker that once was routinely used to treat hypertension. Over the last 5 years, however, safety and tolerability concerns, along with the introduction of new classes of antihypertensive medications with increased mortality benefit, has relegated to a less optimal option. The cost access factors might mean it's still being used. So in the NHS, where I work, I would still use Procardia if I can't get access to the other drugs previously mentioned. So you would administer it this way: 10 milligrams, 20 milligrams, and then you might switch to labetalol, 40 milligrams, and then you would consider other options. Again, repeat the blood pressure every 20 minutes. Magnesium. This stabilizes the basement membrane. It's used for seizure prophylaxis and is a standard of care due to ability to reduce mortality. It's recommended in severe seizure risk patients. However, it does not prevent progression of disease. So 10 to 15% of mild patients will progress on magnesium. These are the toxicities involved. So you might get a decreased patellar reflex. You might get respirations, cardiac arrest, decrease in urine output. Its contraindications include myasthenia gravis, which is a chronic autoimmune disorder in which antibodies destroy the communication between nerves and muscles, resulting in weakness of the skeletal muscle. Renal failure, fetal effects, as in the changes in the baby, including depression after birth, decreased variability, decrease in baseline. These are all reversible. If a patient is showing adverse effects from magnesium, you can administer calcium gluconate, so 1 gram every 5-10 minutes, to help alleviate the adverse effects. Management. Fetal monitoring is essential and can be done with external continuous cardiographic monitoring, EFM, which collects data on heart rate and uterine contractions. So this technique has a number of false positives, resulting in the inability to properly predict fetal hypoxia. Central fetal monitoring, which allows the nurse to remain at the station, or intermittent auscultation, which allows the woman to move about more freely and have more control. It's important to have fluid management, so give 80 cc's per hour, and it's important to reduce risk of pulmonary edema, check for oliguria. Diuretics are are only used for pulmonary edema. Blood pressure needs to be managed. Anesthesia can be used though there are risks of hypertension or hematoma with low PIP. There is also general endotracheal anesthesia in induction risk of stroke due to spikes in blood pressures. When to deliver? In pregnancy with severe hypertension, delivery depends on gestational age. If less than 34 weeks, steroids are indicated and then delivery. If over 34 weeks, delivery without steroids. In non-severe features, induction at 37 weeks. These are patients with normal labs and better outcomes, with no increase in cesarean section rate or adverse fetal outcomes. Postpartum. After the birth of a child, guidelines recommend a 12 to 24-hour course of magnesium if they have severe features, because they're still at risk of seizing. To monitor urine output to confirm magnesium has cleared renally. It's important to have a course of antihypertensives to control blood pressure and watch for any late onset and monitor lab abnormalities until patient begins to recover. This is when you can use NSAIDs, non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, naproxen, and celecoxib. These are widely used to relieve pain, reduce inflammation, and bring down a high temperature. These are not recommended if the patient has uncontrolled hypertension, poor renal function, oliguria, or low platelet counts. Patient will have a follow-up within a week. So we'll move on to our case study now. So our case study was a 40-year-old Caucasian, British white female, who had gravida 2, para 1. She's had 2 pregnancies and 1 delivery, with 1 pregnancy that did not survive the gestational age of 24 weeks. Patient was currently at 37 weeks and 3 days. She presented to an obstetrician complaining about severe headaches. Her medical history included hypertension for 2 weeks, which was reported as mild with no medications given. She has had an IVF for this current pregnancy. The fetus was appropriately grown by recent ultrasound, and she had a normal evaluation in the office a month prior. Patient was referred to a gynecology clinic in hospital for further investigations. So her workup. Her vitals revealed blood pressure of 158 over 102. Her lab showed an aspartate aminotransferase of 100, and chromium of 0.9, 3+ protein on urine analysis. We checked her sterile vaginal exam, and it was 1 over 80 over -2, which is soft vertex. Sterile vaginal examinations are conducted by a qualified research nurse or a doctor to determine progress and status of labor, as evidenced by dilation, effacement of cervix, station of presenting part, and presentation of feet. So her hospital course, the patient was observed overnight, and a decision was made to put the patient on induction therapy with cytotec given overnight. This is an oral medication commonly used to induce labor. It works by softening the cervix to allow easier dilation, which is known as ripening, and producing contractions. Pitocin was given in the morning, which is a synthetic version of the hormone oxytocin, which stimulates the muscles of the uterus, causing contractions to begin. This is administered during the end of pregnancy to get the process of labor going. Her blood pressure at this point was mild at 140 over 90. So the following timeline demonstrates the situation after induction. At 6 o'clock, the patient's blood pressure was 170 to 102, and the patient was suffering blurred vision. 50 minutes later, it started dropping to 167, and then down to 152. So pitocin was started. An hour before after the first blood pressure, the patient started rising again. Blood pressure 154, dropped to 150, and then at 7:45, the patient suffered seizure. So we put them on magnesium sulfate bolus. 2 hours after the initial blood pressure, the blood pressure rose to 165 and then settled at 168 over 107. So labetalol 20 milligrams IV was given. That's the beta blocker. At 9:10, which is 3 hours after the first blood pressure, the physician was called into the room. At 9:17, IV labetalol 20 milligrams was given again. And then at 9:20, seizure, patient suffered another seizure, so we decided for cesarean section. The cesarean section went off without any problems, and the baby was born a good way, and the patient recovered after um, maybe a day of outpatient. Um, yeah, so this is generally how you treat and the situations that usually occur during hypertension in pregnancy. Anyway, thank you very much. Bye.